So my name is Aoife O'Donoghue and I work with an Assistant National Director working with Access and Integration with Disability team. So for today's event, we're going to have an opening from our CEO, Bernard Gloster. We're going to have a collated presentation regarding the single point of access. We're going to a presentation from Mary Dorn on recruitment and retention. Mac McLaughlin is going to give a presentation on the Autism Protocol. Then Clary and Anne Burke are going to give a presentation and an update on the roadmap. Then we're going to have a really innovative, participative and engaging project regarding St. Gabriel's in Limerick and a project regarding the new development of a CD&T in that Limerick area. And then Bernard Gloster, our CEO, is going to close it with the Now and Next. So I'm absolutely delighted for everyone who's taken the time to come to this event. Again, it is recorded, the slides will be shared, and engage as much as you wish to in the chat function. So thank you, and I'm going to hand over to Bernard Gloster, our CEO.
Right, thanks very much, Aoife. So I won't delay getting started. It is particularly important that we do this. I'm presuming on the call in the participants that we have, which is now creeping up above 400 and still climbing, that we have a share of the people who attended one of the engagements that I did with staff across HSE and funded sector in 2 events in Tullamore and Dublin. So this crosses over between the feedback from that, and obviously also I met with lots of parents and we had a webinar with parents just before lunch. It taps into some of the work that is happening and ongoing at the moment. And then at the end, I will conclude with some specific decisions I have either made or am in the process of finalising in the next short while to make some improvements now based on what I heard, and obviously to focus the strategic direction with the department and the government on the next, which probably takes a little bit more time. Aoife.
Thanks, Bernard. So for the staff engagements, what we did was we got representations from the RIO, so they made nominations for frontline staff. So some of the frontline staff who are joining this call were not actually at those frontline engagements and some were. So I'm just going to give you an overview of what those events were. We actually had one in Dublin and one in Tullamore, and then for our family rep engagements, we had over 70 of the family forum reps who came to 4 different engagements. 2 were held in Dublin, 1 was held in Limerick and 1 was held in Sligo, in order to respond to 3 questions. During those events, what Bernard asked the participants to actually look at was what was working well for children disability services, what were the challenges, and what initiatives or what could make a difference. So throughout all of those engagements, we had a number of different themes. So there was some very specific examples and some more generalised. So what we have tried to do in this presentation is give an overview of all of those themes and respond to you to let you know what action we have taken regarding them. So these are the key themes. Referral pathway. Many people, especially our parents, said that the referral was sent to primary care, then back to them, then to CD&T, and then back to CAMS. We also had engagement with our GPs who said at times when a child presents to them, they do not know where to refer that child to. So we'll be presenting this afternoon on the single point of access, and it's a critical way forward for all families so that they don't have to refer their child to a number of different places, that it's a single point and making that process easier. Care coordination came up, technology, communication, pilots and initiatives, and this is from many of the staff teams who had actually been innovative, been creative with new ways of doing things and things that they knew would make a real difference to the families across all our different teams, be that CAMS, primary care or disability. We've taken many of those initiatives, we've looked at them and tried to collate that learning to ensure that it's standardised across the country. We're also looking at our staffing. Regarding, there was a number of issues raised regarding staffing, recruitment, retention, and Mary Dorn will go into that in more detail, and then the interdepartmental issues that were addressed. So I'll cover them in a summary version. The PowerPoints again will be shared and there's more detail available if anyone has a query following this event. So the first point is regarding the single point of access for children. So what we have done is we have a presentation today that is an example of good work that was done across CHO 8, 9 and also with our colleagues in CAMS about how we can collate what they were all doing in slight separation, but taking the good learning from that, collating it and rolling it out nationally. And we also will be holding a webinar on the single point of access in July for all our colleagues here on the call to actually participate in. We're looking at our waiting lists across children with disability services. Many families present the case of that window opportunity being lost as their child sat on a waiting list. And there is also a lot of coverage on waiting list times and how long a child waits in a waiting list. So Bernard Gloster is now going to establish a performance call. These will be with the RIOs, the IHA managers, looking at the waiting list, looking what we can do regarding that, and the oversight of any challenges, anything that is actually hampering the active response to those waiting lists. Another thing that came out quite clearly was the PDS model and the effectiveness of it, and how the quality of that service was very, very good. However, the quantum at times needed to be increased. So one thing that has come out from the parent engagements and from staff was the benefit of early intervention, engaging with those children and those families under the age of 6. And this is across all our teams, but primarily our CD&T and primary care. So there's a pilot project that we're engaging with one of our Section 38 service providers, which would be a nurse-led project, engaging with early intervention, coordinating the skills, the knowledge, and those universal supports for those families. And what we're doing is that this will reach into our teams across 3 community networks and our CD&Ts to enhance what has already delivered, and also then look at an evaluation, say, has it been effective? The plan is that this will be operational Q3, Q4 this year. Regarding the AON, as many of you are aware, there's a lot of coverage regarding AON around the request for AON, the processes of it. So just to assure everybody, there's a lot of ongoing engagement with ourselves and the national team, with DESITY, regarding our processes and what we can do regarding it. There will be a webinar come the end of August, start of September. But from a national perspective, we have appointed 2 staff to take a lead regarding AON, looking at it from a quality initiative perspective. Many of our families spoke about the need for using CDNM's time, clinicians' time, actually to maximise what is being done. So our engagement with families was only for families who are using our CD&T. But this point is actually relevant across all our children's services, where there's one point of contact, a consistent point, that they don't have to ask multiple different clinicians or staff for an update of where their child is or where they're progressing in. So the CEO has given a commitment that we will look for this to be appointed through the estimates, that there's a key person that the parents can actually engage with to support them on that journey of engaging with our services. The other thing is regarding administrative resources. An ask from families was that we maximise the use of our clinical team and their professional knowledge, as opposed to them spending some time doing administrative burden tasks and spend more time with assessment and intervention with the children. So the CEO has given commitment to review that and evaluate where we can actually increase the admin support to the teams, and actually then therefore give more time to our clinician to engage with children. One example that was given by a parent through our engagements was that they actually engaged with SLT, and the session was videoed. And then the mother went home with this video, was actually able to actually practice the clinical guidance that the clinician had done. It was an SLT session, and immediately she was able to actually model that and do that with her child. And she gave a parallel process where she had engaged with a HSE team, and the documentation took over 2 weeks, the guidance took 2 weeks, and it was in a Word document, whereas the benefit of actually seeing how the clinician engaged with the child was much more beneficial. So we're looking at the use of videoing of children's sessions where appropriate across all our teams, and that's primary care, disability and CD&T, especially for that modelling piece where you're asking parents to take on tasks and grow and develop that child's endless potential. Also, an ask from parents has been for us to have more accessibility to social stories and visual tours of our buildings. Many of the children that we engage with communicate without words, and the use of visual cues are much better at preparing them for that appointment. So they said that there is some areas of the HSE that are doing this really well and really effectively, but they would like a consistent approach seen, especially for children who communicate without words. It prepares them well and makes the appointment a lot more successful. So that's something we're looking at across all our teams. Access to medication came up from families, especially at times for the child who was in a CD&T seeking to access CAMS. So we have to engage more with our CAMS team regarding how can we do that, how can we ease that access for it and share that information that we have on that child. But parents said they want more timely access to medication. And we had a father who gave a very vivid example of the delay in him getting access to the appropriate medication and what the impact was on his family or his child. And it was actually that response is needed across all our teams. And the more coordinated and integrated we can become, the better the outcomes can be for the family and child. Respite was an issue that came up across all our engagement events, but especially for families, they had a lack of clarity on the pathway for respite, the various respite options that are available to them, both centre-based, after school, and with the summer months coming, summer camps, some had and some hadn't access to July provision. So what we've done is we've looked for a number of respite initiatives that we could immediately stand up and respond to following the engagement events. So for example, in Sligo, there was funding given for a 5/7 respite service. It is a respite service that has been fully developed with the support of estates to be responsive to children and access to them. At the moment, the children share a service with adults. So it's the adults are in some weekends and the children are in other weekends. So by opening up this service, it will see a 7/7 service responsive to children in the Pierce Road in Sligo, which is a really lovely location. But it not only enhances the support for children on a waiting list for centre-based respite, it also will enhance the respite for adult services, especially as many parents raise concerns regarding their child having access to respite, and as they turn 18, the pathway being unclear for that adult. So it will increase access to respite across the Sligo area. We also engaged with the service in Cork regarding primary notifications and recruitment of staff for respite options. That is for both centre-based and after-school options. So there'll be further enhancement for the Cork area. And there's another number of respite initiatives. There was also the establishment with Enable Ireland on Friday night. They opened a brand new respite centre, which is 3 new bedded services. And they have a self-contained respite service that we're hoping to engage with them regarding the establishment and opening of it, which would be a service that will enhance and respond to that child who may not be able to stay with other children and have more complex presentations. We have concluded a respite paper with the department, and we hope then to advance that regarding a consistent approach for respite with a multitude of options, being that PA, home support, engaging regarding our paediatric complex packages also, so that families have a number of varying options for respite. A lot of families also outlined the fact of a child being socially engaged in their community and how we can do that and support that. So we've engaged with the GAA regarding their cool camps for 2025. So for 2025, we will have 40 accessible camps that the GAA will be running, and we'll be working in collaboration to support them with those camps. And we also have engaged with them regarding the mainstreamed camps and accessing and engaging with them regarding training and development and understanding of the supports that they would be able to introduce to enhance the experience for children who have additional support needs. So that training and engagement is ongoing, but it's about actually supporting and engaging and working in partnership with the GAA. We're also hoping that our engagement is twofold, so that the coaches and the training, and sometimes as many young people who actually assist with the coaching and development of cool camps. So as their understanding and of disability services grow, there's a wider societal impact on it. We also are going to host a 2-hour webinar regarding respite, share some of the good learning, the good initiatives, and the ability to be innovative at how we respond to respite needs to children across this country. Many families actually discussed the balancing of their role and their engagement with the team, so that when we use the family-centred practice model, where the balance of them having to coordinate to engage regarding it. So what we are hoping is that we'll have the key worker to assist with it, but we also have Enable Ireland who are launching a Parent Connect programme tomorrow in NUI Galway. So this saw a pilot project that took place in Galway City, in Tipperary and in Cork, where they got parents who have been utilising the system for a number of years. They have a lot of experience and they become a support to parents who are new to the system. As many people can appreciate, the engagement in our system and the model can be a challenge. So it's a kind of peer-to-peer support with the oversight and support of our agencies. So we're hoping to look at that evaluation and expand it further. And parents have often said that peer-to-peer can be a lot of help. For some parents, it won't be an option, but for others, they will see it as a key support. Move on there, Laura. From our family forums, this is an opportunity for families to engage, to articulate and to raise issues. So some of the family forums have been seen as hugely beneficial. Parents have articulated to us that they feel this is a really good initiative and good support. And for some other localities in the country, it hasn't been as successful. So what we want to do is share the learning for those family forums and get that feedback from families to say what worked and how that communication really helps. So we have really positive examples of that through the country. I want to support some of those other family forums. There has been an ask through our engagements for satellite clinics. So especially for children who have physical disability, their parents have to travel many times to Dublin to access clinical supports and hospital appointments, and sometimes they may have to travel to Dublin for varied appointments, so the coordination of that. But also we've engaged with Cerebral Palsy Ireland about how we can establish some of these hubs to the support of the child with a physical disability. And as well as that, we're hoping to engage regarding a national clinical pathway for these children. So also for children with cerebral palsy, but additionally for children with physical disability needs and the support. Also, our seating clinic, many parents said that their engagement regarding a seating clinic, or any families who need to get a child into a specialist chair, moulded seating, it takes a multitude of appointments to get that seating appropriate. So what we've done is there was a business case in the system for Enable Ireland, and we have granted funding for this business case, which will now see the expansion of the Enable Ireland seating clinic and bringing it more local to children and to families. We're also conscious of the support of parents and siblings for children who have an additional need. So we've been engaging with our colleagues who currently provide support to HSE for our EAP programme about actually can they provide additional support to some of our parents and to their siblings. So that's in an initial engagement, and we're progressing with that. Also then, there has been a really positive engagement regarding a development of a new CDNT in South Hill, and our colleagues from St Gabriel's Foundation will actually share that with you at later part in this call. We're engaging with the states also around evaluation of the facilities that we provide CDNTs. Some of them are in brand new bespoke buildings, but some need increased accessibility in changing places. So we're doing an evaluation of that at the moment. But we also have seen the importance of the co-location, where at all possible, the success of that. And we heard that directly from staff teams, where CDNT primary care can be co-located. It does make a difference in primary and CAMS. Access to equipment and technology. Many parents raised concerns regarding access, especially to tablets. So we're evaluating that and ensuring that children have timely access to equipment, especially when they communicate without words, the importance of that tablet, and also importance of the clinician being available with the appropriate apps and the appropriate training to families. It's a key ask for families. It's something we need to progress. There also has been a need regarding aids and equipment. The CEO's memo has definitely made a difference regarding timely access to equipment for children. But one thing we've learned through our engagement with families is at times the rep and access to actually the rep fitting the equipment or providing the appropriate training to the parents, there has been a delay in that. So we need to be monitoring that, ensuring where possible and where there is delays that we can actually address them in a timely manner. Also then, there's an ongoing engagement with the WHO regarding a wider project for the use of assistive technology. And this is about where assistive technology can help us from a workforce perspective, from a clinical perspective, but also a wider society perspective. So there's ongoing engagement with them regarding it. We're going to be holding an engagement regarding the AON, and we also are having the importance of the cross-sectoral meeting regarding AON with parents, with schools, and standardising that. Anne and Ben will do a presentation later on how we're improving communication and standardising our communication across all our teams. So through our website, and instead of 96 primary care teams or 93 CDNT teams having to develop a different bespoke approach, that some of these can be standardised and shared across teams. We're also looking at the CDNM, and where there is families looking to access CDNM. At times they're having to balance quite a large caseload and also engaging with their workforce and many issues. With families having timely access to that CDNM, or where if the key worker can take on those roles. But many families do not want to engage through the use of phones or emails. They actually want that face-to-face engagement. So we have to talk to our CDNMs regarding that. Also a strong ask for us to actually hear the voice of the child. Through that co-design element, how can we actually engage with children who've utilised our service, what they felt has worked and how we do it. There also then has been a number of progress regarding our children posts, our staffing posts. So Mary Dorn will go into this in detail, but as part of our national service plan, there's been 20 senior posts, 20 basic grade posts that have gone into the system. All of the RIOs have got their allocation based on population health, and what's been clearly articulated in that letter is to identify the teams where these posts need to be filled, but also there'll be a 3-month timeline for those posts to be filled, to get these posts in by the end of the year. So to prioritise the recruitment of these posts and get staff in doing assessments and intervention with children. Many of the existing CDNT posts, there was a number of issues raised, and Mary Dorn has engaged with the Director of Peoples in all the different regions to try and address that. Many of our staff and our families address the need for actually the use of more health and social care assistance. So we had 25 of those posts allocated last year and we've 20 this year. So all 45 of those posts are going to be allocated to the RIOs to respond to that need, and they will be as well within that 3-month timeline of getting them recruited. We also have been successful with the recruitment of 15 trainee psychologists. So they will commence from the 1st of September. The allocation is done again by Population Health, and all the RIOs have been made aware of that. So they're specifically funded through Decity to respond to the need for that development of posts. Thanks, Laura. So there was a number of departmental issues that were raised. I'm just going to hand over to Bernard just to address these.
Yeah, thanks, Aoife. So just very briefly to say to people, obviously when we talk about integration and access to service, there are issues that cut right across our service users, but that actually are not within the remit of the HSE or within the gift of the HSE to resolve, and they range right across from the Department of Education to Department of Social Protection and Carers Allowance, Department of Transport, Housing, and so on. And I have brought those both directly and also through the department to the Cabinet Committee, which meets on disability and which I participate in, and which includes all of those ministries. So there is some better chance that policy direction can be tightened up on that to improve that different type of access than the access we talk about. The Department of Education, I think, as people know, have committed to building their own therapy service, and that's going to start with special education, and I imagine will start in and around, well, the recruitment will probably start in and around summer, late summer of this year for that. Thanks, Aoife. Thanks,
Bernard. So we're going to move on now to the single point of access. Again, there was a number of initiatives. So CH09, Olive Hanley, Donald Kelly from a CAMS perspective, they've all engaged with this presentation, but Michelle Howard and Niamh Clark are actually going to present it and share the learning and the principles from it. Thanks, Michelle and Niamh.
Thanks, Aoife. Good afternoon, everyone. And Niamh and I are delighted to have this opportunity to share the project with you all. See a number of our colleagues from the CH08 area on our call. So Niamh and I are just, I suppose, sharing one part of a larger project. And as Aoife said, we have already also linked in with some colleagues from across the country, as there were many people attempting to address, I suppose, this challenge. I'm just going to talk a little bit about the approach that we took, and Niamh will go into more details on the specifics of the actual process. So I suppose it's no surprise to anyone on this call that this would fall in that category of a wicked problem, multiple stakeholders, multiple perspectives, and so it's not an easy challenge to address, but we attempted to do so by using a human-centered design process. Thanks, Laurie. Can move on. The human-centered design, for those of you who aren't familiar with it, aligns with the Action Plan for Designing Public Services, and that which was published in 2022, and it's different from the traditional approach in that we start with the user, we co-design across services, and we try to move towards a solution, I suppose, very quickly to learn from that. Thanks, Laurie. You can move on. Yeah, you can move past that slide. Thanks. So with human-centered design, we start with a how might we question, and for this project, and specifically for this area of single point of access, we asked the question, how might we optimize existing resources to create an equitable, streamlined, family-centered referral process, ensuring timely access, clear communication, and seamless clinician collaboration. And with the human-centered design, we start with the users, which for this project was families, service users, but also very much frontline clinicians. And systems are viewed in context of each other. So this was a cross-care group project, starting with disabilities, mental health, and primary care. And they were brought together to design together. Like I mentioned earlier, we use this phrase bias towards action in design. And that means that we do spend some time in that problem space and trying to learn more about it. But we moved very quickly towards co-designing solutions that we can test, because we understand that it is by testing the solutions that we can really challenge our assumptions about what's needed, what will work, what won't work. And we do so with this openness to understanding that frequent adaptations may be required, but it is by doing that we will learn. So this is just a high-level kind of overview of the project. It was across 6 months. It was very important that it was done in a very time-bound manner between June and December of last year, across the 6 counties of what was CHO8, so Longford, Westmeath, Laois, Offaly, Louth, Meath, and very importantly with the 3 care groups: disability, mental health and primary care. With that acknowledgement, I suppose, for it to work anywhere, it has to work everywhere. We started, this is image of the double diamond of design. We started in that discovery phase. And from that, we had 6 key recommendations that we looked at. Now, for the remainder of the presentation, Eve is going to focus on one of those 6, which was the single point of access. But we moved very quickly to designing, co-designing with our service users, clinicians and managers across the 3 care groups, a solution, and then tested that. So I'll hand you over to Niamh now.
Hi, good afternoon. Delighted to be with you. So just carrying on from Michelle, and just to reiterate the fabulous work in CHO7, 9 with Olive Hanley, and with CAMS and Donald, Sinead and Sarah, who came together for many presentations last week to come up with this. Just this one was selected to be presented, but it was with the blessing and the fabulous work that's been done across all other areas. So 140 service users were consulted across 40 locations in the 6 counties. So that's CAMS, YAMS, Enable Ireland, CD&T and primary care. Their voice was paramount to moving forward. And the second really, really important group, as Michelle has stated, is the frontline staff, who often know how things can work better, do work better when we all work together. So without the managers, there were 35 of them as well, we needed their blessing. And the support team, which is referenced here, is the IHA manager, the heads of service. It was crucial to get for mental health, disabilities, primary care, the project management office, the digital team, and the service user engagement led. So each of the 6 strands, then there was a designated lead, and it was coordinated then by the project lead. Thank you, Laura. So we'll move on to the next slide. So basically what we did in the design, you see the double diamond, and we're going to focus in specifically here on the single point of access, as Bernard wants this really, really drilled down into, and the good work, I suppose, demonstrated across the country. So who are we designing this for? What else has this problem? Who else has this problem? And what has been done? So we asked parents, we asked the young people themselves, we listened, and we empathise. And what we soon realised was actually the problems that were in CD&T are in CAM service, are in primary care. Everybody across CHO8 was grappling with long wait lists, referral acceptance, assessments, intervention, multiple points of access, being denied access in different locations, parents unbeknownst being rejected from multiple care groups at the same time. So the issues with the referral process was clear, disjointed assessment process, and a lack of shared working. Clinicians were saying, we used to work alongside our colleagues and now we're very much siloed. So the key features of this whole intervention for 6 months was optimizing existing resources. We absolutely know that we can't have new staff for every single process that we need to have staff. We've got to optimize what we have and seek to get further staffing. It needs to be equitable and streamlined. So we can't have one family in one part of Ireland having access and another family not having access. It needs to be family centred. We need to keep them and hold them in the palm of our hands, and around them the service is delivered. The timely access, parents over and over again, and like everybody on this call, you're all staff, you know the heartbreaking stories, and it's often clinicians and managers that are front facing that have to listen to parents. Clear communication, who's speaking to the family, when and where, and the seamless collaboration between clinicians. Next slide. Thank you, Laura. So the key principles overall for the whole project was one referral pathway from the service user's perspective. And we appreciate that this will look different in every area. And as Olive and Donan have said, it's different in their area, but the same principle. From the parent's perspective, there's one point of entry. Clinicians process the referral. So in CHO, where this was piloted, and the great lead, Kim Tucker, and the team in Longford, the CD&T, the primary care team, the CAMS team, fabulous and Trojan work there. From the parent's perspective, the referrals were gathered in one location. They were jointly reviewed by 2 clinicians, and I'll say a little bit more about that on the next slide. It was then that we would be able to record when they entered the system and what happened to the referral and how they were communicated with. Universal intervention, parents said, we need to be, from the very beginning we make our referral, we need assistance. We can't wait on a wait list with nothing happening, and the process needs to be seamless, and the communication to us needs to be timely, and it needs to be clear. Thanks, Laura. So the design referral process. So this piece here, what we decided was, with mental health CAMS YAMS we have in our area, disabilities and primary care, it was agreed, and it had to be a trust between all 3 care groups, that 2 clinicians, one from CD&T and 1 from primary care, which rotate every 3 months, would review the referrals that required 2 disciplines or more. And these tended to be the referrals that were being bounced in and out of primary care, in and out of CD&T, and in and out of mental health. So those 2 clinicians, their decision was final. They reviewed the information that was sent in by the parents on the NAP and the AIF. If it was required, those clinicians then saw eyes on the child, very, very infrequently required, interestingly. Universal strategies were given to the parent and a decision within 2 weeks. So the parent knew at the end what team and who team was accepting their child based on the referral reason, based on what the parents had said, or the referring GP, nurse or clinician. The parent was given information on that. The contact details of that team were then provided, and the parent knew from then on where they lay and where they were going. It was really important that the clinicians were rotated. If they were on leave, it was up to the CD&T manager and the primary care manager, who did a superb job in making sure that that referral clinician meeting was always staffed. Thank you. So the next slide then, what we know, sorry, just go back one line. The referral, the clinician time was saved, because what we did was happening previously in CHO8 was that CAMS were reviewing the referrals, primary care were reviewing the referrals, and CDT were reviewing the referrals. And yet there was no agreement at the end of the day at times. Response to parents was quickly improved, and as a result of that, then the parent communication was improved and the collaborative working improved. Closing remarks then: all children in the area had access to a streamlined referrals and simplified care pathway, which was a huge success with both the clinicians and to the parents. It enables integrated ways of working. As I said, it was a clinician from disabilities and a clinician from primary care that rotated. We had a loop into CAMS and a loop out of CAMS. So if those 2 clinicians identified that it was required that the case should be in CAMS, they overrode the decision for a GP referral and allowed the referral to go into them, which they reviewed and held on to or asked further questions. And there was also a loop for them then to come back out. So we closed that loop between the 3 care groups. What it did mean was that we ensured that children are accessing the right service at the right time, and they knew exactly where they were heading. Delighted to share more details after this. Thank you.
Thank you, Michelle and Eve, on that. And just to allow people to know what's happening regarding that. So the single point of access, we're going to be engaging over the next 2 weeks regarding the design of it. There will be workshops being led by the RIO and the IHAs across the 20 IHAs. So there'll be 6 different regional workshop and engagements planned for potentially October. And there's a number of questions and queries coming in there just regarding primary care and staffing allocation. So as well as looking at a single point of access, we're also needing to look at the build up and the staff and the workforce regarding those teams, not only the CD&Ts, but the primary care and the CAMS teams in those localities, and our ability to respond. So the performance calls will be addressing some of that by looking at workforce and looking at those issues, but we also will be looking at workforce across CAMS, primary care and the CD&Ts based on those IHAs prior to October. So there will be ongoing engagements regarding that. I'm now going to introduce Mary Dorn, who's a workforce lead with responsibility for disabilities. Thanks, Mary.
Hi, thanks very much, Aoife. So just going into what I'm going to cover in this, I've met many of you before, and what my role is to do is to bring up the workforce and disabilities up to its funded level. So I'm going to look at the current status. This does concentrate on CD&Ts, but I would say to you, everything that's outlined here is also absolutely mappable to primary care once we get into that space. So all of the initiatives here, I would hope would have a beneficial impact on primary care, and I'm very happy to work with my colleagues to make that happen as well. I'm also going to go through the 24 and 25 initiatives and how they've actually impacted our baseline in our workforce, what we're going to do for the rest of 25 and 26, specific actions to do with CDNTs, and then look at how we benefit from the wider landscape. So there was lots of stuff brought up in the engagement days, and I'm going to address them throughout the whole presentation. So look, on the good news side, we've had overall in disabilities, we've had quite an increase of growth. We've had over 1,100 people have joined disabilities. That's a net increase after all the recruitment since January 24. And this year to date, we already have 255 more staff than we had in December. But looking specifically at CDNTs, so CDNTs, look, we have a lot of lead agencies, which is just in the next slide there. So it is, Laura. So all of our lead agencies are reflected in the figures that I'm going to talk about now. One thing I would say to you is that while we've had really good growth, and you can see it, we've had the graph is going the right way is the best way to describe it. Since April, as of April, when the last Children's Disability Network Team census took place, we've had an increase overall of 415 since October 23. So in the last 18 months, there's been 414.5 extra staff working in Children's Disability Network teams across the 93 teams. That's really good news. It's not good enough. We still have quite a level of unmet needs, so we'll continue to address that. And where we're hoping to go to quite soon is up to our fund level of nearly 2,500. I'm not saying that our funded level is actually the level that we need to be at, and Anne is going to talk about the National Disability Authority review to look at the optimal staffing level from that perspective, but it's going in the right way. However, going on to the next slide, you can still see that there are a lot of unfilled positions. Good news, we've reduced our vacancy rate from 18% to 18 months ago, it was nearly 30%. That is absolutely phenomenal growth that has been on the backs of all of the work of the people on this call and the recruitment teams that work them and the agencies and the HSC. So that is a really good way. I think people can feel the difference themselves in the teams, but we still have an 18% vacancy rate. We still have nearly 450 funded posts that are unfilled. So going to the next slide. Just to get in on a region perspective, look, there's massive discrepancy between the different regions, and that's the HSC, Section 38s and 39s on the levels of vacancies that they have, and you can see them there. Look, I'll have that report out in July on the CDNTs, and you'll be able to see on the specific teams the levels of vacancies. So next slide. Okay, so what did we do in 24 and 25 that's got us to this point? Well, we had huge partnership initiatives with our HSC teams and across the Section 38s and 39s, massive effort to recruit, massive effort to absolutely squeeze out what we could from the market. We also opened up the HSC panels, the HSC advertising streams and the candidate pools to our Section 38 and 39 colleagues. And it's not that we're any better at recruiting in the HSC, in fact we're not, but what we do have is a massive standing in the public's eye and internationally, and they've been able to really maximise their recruitment potential through using those. We also launched our first CDNT under a postgraduate sponsorship for OT, SLT, physio and social worker. We're looking at further initiatives and I will be working with the regions and looking at how primary care can be also optimised from that perspective, because we know, for example, that a substantial amount of people come senior into disabilities and they come through primary care from that perspective. So going into the next slide then, that just shows the flyer for the recruitment sponsorship. Okay, so moving forward, the other elements that we did this year is we worked a lot to improve perception of working in the CDNTs. And thank you to everybody on this call. A lot of you are involved in a lot of engagements with multiple ones. And we know that every time we have one of those engagements, every time we have a webinar, we have a spike in job acceptances and we have a spike in job applications. So we have a lot of content, and we've worked particularly with the Section 38s and 39s in generating a lot of content which can be attached to job offers to encourage people to take them. We established the therapy assistant grade, and this year we'll be working on the behavioural assistant grade. And also we have a number of bespoke recruitment pathways for the absolutely chronically unable to fill posts, and we've had some small success there. But look, there's no one answer, it's the multiple layering of initiatives that brings us to where we are. So if you just want to go through the next few slides, Laura, you'll see the kind of different content that we've created there. You can go through them all, and thank you to St Michael's House and Enable Ireland who were part of those webinars and part of those videos. So just looking at from an engagement perspective, we always keep disabilities to the forefront in every single engagement that we have. So on the left hand side, all CDNTs, disabilities, Section 38s, 39s and the HSE are represented in these. In fact, all of health and social care is represented in these, primary care and CAMS as well. What we want to do is improve the perception of working in disability, so this is a really worthwhile career to have. So if you want to move on there. Just looking at the measured impact. In the last 18 months, we've increased across disabilities by over 1,200. We have the highest rate of growth in the community services, and within CDNTs, we've increased it by 414 in the last 18 months. That's a workforce increase of 26%. So what are we going to do in 25 and 26? We're going to concentrate on growth in our high vacancy CDNTs. We're going to concentrate on growing pipeline. I would say any pipeline growth for CDNTs, for disabilities, has an absolute beneficial impact for primary care and CAMS as well. We're going to modernise our recruitment journey and also work on retention. So just looking at the pipeline, the next slide. Within 2025, as I said, we launched the first CDNT campaign. We're going to expand that out, and part of that I'll be looking for is funding, also for potential sponsorship into primary care as well. If that funding is available, that's really, really important, because I said that's the route into disabilities and the senior posts. Apprenticeship model has been developed for all care groups. The clinical placements already into CDNTs, it's increased by 30% in the last 2 years. We'll be looking at increasing clinical placements across the HSE, and I work really closely with my colleagues on the health side, so for primary care and CAMS on that. There's going to be growth across all care groups in HSCPs, as announced by the government, and we need to work to diversify our workforce. Now, the one thing I would say, therapy assistants. There was no therapy assistance in the HSE. Through the work done by myself and my colleagues, there now is a therapy assistant framework in place and can be used by all care groups, including primary care and CAMS. And we're going to work on rotations. So just looking at the what are we going to do to deliver? Well, first of all, we need to co-design with all of our colleagues and the funded agencies. We need to scale up our clinical placements, put in place the rotation infrastructure, and have space and for growth within our paying numbers. So just moving on there. For the high vacancy CDNTs, our main issues are about identifying the obstacles, learning from high staffing teams, and putting in place assisted recruitment, which I'm in the process of doing on a pilot site at the moment. And for the next slide, for our recruitment journey, what we need to do is identify the main obstacles, learn from faster recruiters, and constantly review and respond to modernise our processes. So I'm just going to skip forward to the retention slide, because everybody's going to get these anyway. Look, the one thing I did want to talk about really just to you is about retention. Obviously, our first point of any workforce strategy should be retention, and is retention. We do know that financial incentives have a high impact on recruitment. They have a reduced impact on actual retention. The main factors based on research are career progression, work flexibility, professional development, professional support, and remuneration and incentives. I'll be working with you throughout 24 and 25, even 25 and 26, about how to define the levels of relevant importance. So what's important to you in retention, what do you want to see delivered first, and I'll be working with Bernard Gloster on getting a funding level for that, so we can deliver proper retention strategy and actions to retain our good staff. Okay, so I think that's me done.
Mary, thank you so much for that update, and as everyone can see, there's many initiatives being developed there.
Can you hear me now?
Yes, we can.
Yeah.
Thanks,
so 18 of the 60 roadmap actions have been achieved to date. You'll have seen that in the last quarter report that was circulated a couple of weeks ago. We have 23 actions in train for delivery this year, and I picked out a few salient actions that are under the themes raised in the recent staff engagements. The revised HSE TUSLA joint protocol will be completed by this summer following extensive consultation with HSE and TUSLA staff. Under service access and improvements, welcome packs are now in place for all newly referred children to the 93 teams. We will work under the communication plan that I'll talk about in a moment to standardise the topics that are covered in each of those welcome packs across the country. The aids and appliances review, we're delighted it's been led by the WHO under a global initiative. They have completed extensive consultations at this stage. I'm sure many of you were involved in them. They delivered a workshop recently with the HSE and Department of Children on their draft findings and recommendations. And they plan to have a final report to government for consideration by the middle of the summer. The origin of this was a roadmap action to develop consistency and across all consistency for equipment access and types of equipment for all children and all adults with need across the country. We have launched a survey last week on services privately commissioned to support waitlisted children and families. Again, this was a roadmap action agreed back in 2023. It's to run in parallel with the actions that Mary talked about, increasing our staffing levels in services. Disabilities Capital Plan will be developed by the end of the year, and this will include addressing the accommodation gaps for our remaining CD&Ts where staff are not co-located in one place. As we know, this is critical in order to develop child and family-centred services. Our April data, on a good note, does show changes in the right direction. Our CD&T waiting lists have decreased a total of over 2,000 children in the past 6 months, and this is at the same time as 5,200 plus new children being referred during this period. At the end of April, the number of children waitlisted for CD&Ts sat at 11,447. And again, this is down 5,000 children on the number that were waiting at the start of the roadmap. It is reflective both of the ongoing reduction in CD&T vacancies and Teams works to maximise their efficiencies and quality of service with those new staff in particular coming on board. Under technology, we're developing a short survey for CDMs on Teams' current use of digital tools. It'll run this month. We know during COVID that access to services and supports digitally was very popular with families, but not so much since. We're reviewing currently what digital supports are in place across all teams and 12 lead agencies to see what is appropriate to share and standardise across all teams. And also, in addition, what digital tools and processes that, if they were brought in, would help teams to maximise their efficiencies, where appropriate and where always with families' consent and willingness. Our CD&T IMS will be in place for all CD&Ts by the end of this year. The NDA review is in train now with staff, CDNMs, primary care, CAMs being surveyed, family surveys, focus groups are in train for completion by the end of this year. It is two-part. The first part is reviewing the CD&T model in operation. It's 12 principles, what's going well, what's not going so well, and what the solutions for the not so well are. The second part is to identify optimal staff workload and team configuration of the CD&Ts to maximise efficiencies and effectiveness of our services. The Service Improvement Programme Board also agreed that it would be very important a similar piece of research would be conducted for primary care paediatric services. The review recommendations due out at the end of the year will inform the estimates process for appropriate levels of CD&T staffing to meet the rising demand. And final slide there, please, Laura. Under communication engagement, we've developed a detailed communication action plan, which has now been approved by the Service Improvement Programme Board and will commence rollout in September. And that's my time up. So I'll just finish PDS website phase 1 completion in November, and we will launch our second 6-monthly webinar for FRG members on July 2nd. And finally, the junior review of the family forums in FRGs was completed in April. We submitted it and a HSE draft action plan to the SIP board with recommendations to address the recommendations arising from the junior review. And we expect that they'll be signed off this month. Thank you. Back to you, Aoife.
Thanks a million. Now, our next presentation is from Ben Clooney from Communication and Digital Services. We got lots of feedback from families regarding improving our engagement with them from a digital perspective. So Ben is going to give us feedback on that. Thanks, Ben.
Thanks, Aoife. So yeah, there's a couple of strands to what we're doing online, and the new service that we're developing is a single place for evidence-informed wellbeing, health and services information. We have already published improved services information. We did that in January, and we are currently reviewing and extending the advice and support for parents and carers, and this will be available starting from September. The new information resource based on feedback from parents, they find it challenging to find evidence-informed information. Many are being pushed to information in the States, and we need to do the hard work to identify what the best information that we can provide is. So we're commencing a project to pull together an agreed set of national supports, information, guidance, and we'll be making that available on hse.ie. The first iteration of that will be published in November, and we will be working throughout 2026 to extend the information that is included there, to develop new information to fill gaps. And one of the really important things is to help parents to navigate that information. Currently, we're seeing a number of standalone CDNT websites. There's duplication of effort, there's inconsistencies in different areas. So the idea is to look at that good work that's been done on those individual websites and look what needs to be pulled together under that national umbrella. We'll be applying best practice principles in terms of accessibility and content design, and developing design standards that are specific to disability services. And this new information service will be integrated with My Child on the HSE website. It will also be available through the HSE Health app, and actively maintained and continuously improved in collaboration with parents and carers. Thanks, Aoife.
And thank you for that update. I'm going to try now and go back, if technology will allow, to Mac McLaughlin's presentation.
Hello everyone, my name is Mac McLaughlin. I'm a member of the Service Improvement Programme for the autistic community, and I've had the pleasure of chairing the Autism Assessment and Intervention Pathways Protocol Subcommittee. That is the committee that's developed the Autism Assessment Protocol, and I'm going to talk to you about that today. So our understanding of autism is always changing and evolving. So if you look at the prevalence of autism within my lifetime, from 1966, there was a prevalence estimated of 1 in 2,222, to figures that came out last year but published this year in Northern Ireland, 1 in 17. So huge difference in reported prevalence, but also in the presentation of autism. So it used to be that people thought of autism as a single discrete disorder with a few very specific symptoms. Again, a very different understanding now, where we see it as a dimensional experience across a spectrum of different types of experience across the life course, being dynamic, meaning it's changing often from day to day, and an example of neurodivergence and diversity in general. So the rationale for this protocol comes from a 2017 government report, which had over 200 lived experience submissions, and which mandated the development of a tiered approach to assessment. The protocol seeks to make an imperfect and admittedly under-resourced system work somewhat better. It's not a magic bullet. It seeks to meet people where they are and not seeing them as all the same. That's the essence of a tiered approach, where the required intensity of assessment is determined by the clarity of a person's presentation. If we look at research and practice, independent reviews of both the research literature and of the national guidelines for autism assessment that are used in different countries shows very clearly that there is no one or best agreed approach or instrument for autism assessment. Evidence also clearly shows that it's easier to identify autistic presentations and what might help for some people than it is for other people. Tiered approaches are very common, for instance, in terms of disability benefits or in terms of disability education and health services globally. Tiered approaches are very common. And in autism assessment, they're also common in other countries such as Scotland, Australia, and Canada. Over 5 years, then, the subcommittee which has developed the Autism Assessment Protocol has met very frequently, and you can see there a diagram which gives a rather complicated governance structure. But the key thing to take away from this is that there has been, importantly, lived experience representation at each of these levels. We've also had multidisciplinary perspectives throughout this 5-year period, and we've had intersectoral, that is, across primary care, disability and mental health input from both clinical and managerial staff. The pilots for the protocol have been independently evaluated by the Centre for Effective Services, and we've had consultations with civil society and professional bodies. We are in the process of co-designing implementation workshops which will commence shortly. So just to take a high-level view then, screening may occur in an educational or a health context, or indeed an occupational context. Assessment occurs at 3 different tiers, and I'll describe those shortly. And interventions, really our ethos is to provide interventions as soon as possible, and that intervention should be used as a source of new information to inform your ideas about the presentation, that it should be family-centred, and that it should be inter or multidisciplinary. So we put a strong emphasis on formulation, not instead of diagnosis, but along with diagnosis, as we believe formulation provides a richer explanation of the interrelationship between factors that support or create problems for some people who are autistic. And in terms of assessment outcomes, autism may be identified, may be diagnosed, there may need to be a further period of assessment undertaken, or indeed it may be that some interventions should be provided before a definitive formulation diagnosis can be determined. So let's just briefly look at what is required then. So we have here review, interview, assess, observe and judge. So it's the same pattern of information that's required at each of the tiers. What differs between the tiers is the extent of assessment required in order to develop useful information about each of these 5 elements. So you can see here review case notes, referral motivation, previous tests, interviews, of course, for developmental and clinical history, assessing particular features that might seem appropriate, observing in Tier 1, informal observation could be in clinic, home or school settings, or other, and I guess we stress naturalistic settings. And of course, judge is the clinical judgment which synthesises all this information. Often presentations will not, however, be clear, and more intense assessment will be required. Where that is the case, the interview should use some formal autism psychometric assessment, such as, but not necessarily, the ADIR. Equally, in terms of observation, a formal autistic psychometric assessment should be used there, for instance, but not necessarily the ADOS-2. So the distinction between Tier 1 and Tier 2 is in Tier 2, people are obliged to use formal diagnostic instruments, whereas in Tier 3, it may be the case that the presentation is still unclear even after using those instruments, and therefore it may be important to bring in other specialists or to do additional forms of assessment, for instance, for intellectual disability, for mental health difficulties, language delays, or other co-occurring health or neurodiverse conditions. The protocol promotes providing interventions as soon as possible and assessment as an ongoing, not a once-off event. In terms of outcomes from assessment, the same outcomes in terms of making a formulation, identifying needs and determining a diagnosis are provided at each level, Tier 1, 2 and 3. And then in terms of the different sort of interventions, whether they're universal services, targeted, or whether they're specific to individuals, again, they're all provided through each of the levels of assessment. So in summary, the protocol provides a level of assessment appropriate to the presentation of the person. It sets out the pattern of information that's required to be collected in order to determine if an autism formulation, diagnosis and services are appropriate. The clinician decides which tier to do an assessment under or when to move to another tier. The clinician decides how to assess someone, if, when and which instruments to use, and the clinician decides how long an assessment should take. The clinician is required to use a pro forma to write up their report, but of course they can supplement this. And they're protected by assurance that the pattern of information they've collected under the protocol is clinically signed off as appropriate at each of the 3 tier levels. Perhaps most importantly, the service user gets the required level of assessment appropriate to their presentation, hopefully reduced wait times, and hopefully more time being spent on providing actual interventions. Sorry it's been such a brief summary, but I hope that's useful. Thank you very much.
Thank you to Mac for his preparation of that, and there'll be a lot more information on the Autism Protocol and its implementation in the coming weeks and months that will be shared with you and your teams. So as everyone can appreciate in disability services, our primary care, our CAMS and our CD&T are primarily on therapeutic input, but it's also about the wider support that we provide. So our engagement with our Section 38 and 39s, and many of our Section 38 and 39s are lead agencies, one of them being St. Gabriel's. So as well as being a lead for some of our CD&T teams, they also provide a number of varying models to support children in the Limerick area. We've engaged with them directly regarding actually what can we do, and an initiative, and their team themselves had identified a project that was very needed our support from a HSE perspective regarding funding, but also the importance of the location of the team being co-located near our colleagues in CAMS and in primary care. We also have identified the South Hill team as one of the demographically deprived teams in the country. Those children that are in those teams have been identified as that. So what we've also done, as well as supporting this capital initiative, we've also been able to engage with them regarding the approval of funding for some key posts that are needed in that team. So what I'm going to ask you now is just to watch the video, and then our colleagues in St. Gabriel's will give you some oversight and context to it. I'll hand over to Laura just to play the video. Apologies now, the video just seems to not go to the end. So what I'm going to do is, we have the CEO of St. Gabriel's and we have the CDNM who's working directly with that team here, and they're going to give a presentation just from their perspective. So we will share the full video with participants, and apologies again that it didn't play to the end. I'll hand over to Teresa and to Aidan. Thank you.
Thanks, Aoife. And I suppose it's the whole collaboration and the whole working together that has really made this project come to fruition. And we're hoping that it will be developed in the next. So I'm going to hand you over to Aidan, who actually works very closely with the communities, just to give you an oversight on her team and the organisation.
Hi. So St. Gabriel's Foundation was founded in 1961. It's a not-for-profit organisation, and we're governed by a voluntary board of directors. So we're a Section 39 organisation. We're the lead agency for 2 Children's Disability Network teams, the South City CDNT and the Treehouse CDNT in Limerick. We also have a hydrotherapy pool and an orthotics service, and they're both social enterprises, so they provide services not only for our children and families, but for the wider community. We have a newly developed children's respite service that provides overnight and short-term respite breaks for children with physical disabilities and complex medical needs in a purpose-built 6-bed facility. And we also have a special school on site with one of our CDNTs based on the Dooradoyle campus. So I suppose both of our CDNTs cover different areas of Limerick City, and the one we're focused on today is the South City CDNT. We provide services and supports for children and families in Community Health Network 7 in Limerick, and it's one of the areas with the highest social deprivation nationally, and we also have a higher than average level of disability compared to the national average as well. I might just move on to the next slide, actually, if that's okay. So the South City team was established in January 2022, and this was to support the alignment of the CDNTs within the Midwest to the community health networks, so to be aligned with our primary care colleagues. The team was developed around the 12 principles of PDS. We started off as a very small interdisciplinary team, so up to, I suppose, 2 weeks ago, we had 6.4 WTE for over 550 children and families, and we're so welcoming of the additional posts now that will help us to grow our team and the services that we're providing for our caseload. I'll move on to the next slide, please. So I suppose, why South Hill? So South Hill is the ideal location for the South City Children's Disability Network team. It's right in the heart of Community Health Network 7. It's a regeneration area. The majority of children and families that we support either work or live in South Hill or in very close proximity to it. It's on an accessible and active bus route. It's accessible by road, and there's lots of car parking. But I suppose one of the really amazing reasons why we want to locate it there is because of its close proximity to all the other organisations in the community. So we'd actually be co-located with our primary care colleagues. It's right next to the primary care centre. We're located right next to South Hill Hub. That's a huge community resource within South Hill. And then Bernardo's and the Family Resource Centre are also located there. There are also a huge number of schools that our children and families will be accessing located in quite close proximity. So this project has been ongoing for a number of years. So the accommodation project actually started before the establishment of the team in 2021, and we worked closely with the HSE to look at their HSE building portfolio. In 2022, the team was established, but we didn't have, I suppose, a set base. So there was ongoing engagement with the HSE and Limerick County Council. Then, as of 2023, we identified a suitable premises with a lot of support from Limerick Diocese. And in 2024, then we managed to secure government, council and philanthropy funding. And as recently as last month, we've now secured HSE funding as well. So this building was developed, I suppose the funding for this building has been provided by a number of different stakeholders, and it's really going to be a really exciting project going forward. And we're hoping that the work on the actual building will commence in the next few months. This just gives you an oversight. I suppose the number 1 here is where our building will be. Then you can see number 5 is the primary care centre, number 3 is South Hill Hub, and number 7 is Bernardo's. So we're really hoping we'll be able to provide a wraparound service for families who are accessing the building and attending our premises in South Hill. The next slide is just a picture of it. So you can just see all of the buildings again there. And I suppose the overall mission for the St. Gabriel's Foundation South Hill Development is to ensure that children living in a regeneration area get the best opportunity to access service. And the building will also provide opportunity for co-working with primary care, CAMS and other community services that are located in close proximity to us. And we're really excited about this project, and we can't wait to see it come to fruition in the next few years. So thank you for your time today.
Thank you, Aideen and Teresa, and it was a really good example of us all coming together for a project. So hopefully we'll celebrate the opening of that in Q1 2027. But the location is key, and as the parent did say that in the video. So apologies for the technical issues. I would like to thank all the presenters at this stage for their time and sharing that information. And I'm going to hand over to Bernard Gloster now.
Thanks, Aoife, and thanks everybody, and thanks indeed, I think, to some almost now 600 people who've given their time to participate on the call. And I see the chat has been busy with lots of different comments. And I think it's important that I attempt to address some of them, because it's ironic when sometimes we ourselves say that we want to talk about collective services for children. We don't want to talk in silos. We're critical of a focus on any one dimension, but then ironically, when there's a focus on one dimension, we want to talk about other dimensions as well, which is exactly a replication of the silo effect that everybody struggles to deal with. I particularly want to address just some of the comments in respect to primary care, if I can. Today was not about leaving aside primary care or indeed CAMS, both of which were part of the engagement sessions and both of which I'll come back to now in a moment. Today was first and foremost the origin of the conversations, whether we like it or not, came out of the reality of a mix of the very good experience of many children and families with services in primary care, CAMS and disabilities, and also, unfortunately, very, very significant challenges in respect of how people experience access problems to disability services, such as to the effect that it's at the heightened level of the government agenda, and anybody who followed the narrative of the last election campaign could see that. As part of the days that I met with many of you and many of your colleagues, I also spent 4 or 5 days meeting with groups of parents in different parts of the country, and I'm also obliged to take on board the reality of their lives, which is what we're somewhat attempting to do today. So I just want to emphasize to people, there's no question of either disregarding or setting aside any other component of an important focus on children's services. There is an obligation to focus on multiple factors, but there's a specific obligation to start with where the experience has fundamentally gone wrong in the context of specialist children's disability services. And difficult as that might seem for any other care group to absorb or hear, that is the reality of life. All of us, everyone on this call, we're paid public servants, and there's a reality to life. And the reality to life is that we come primarily first to respond to what the immediate challenge is in the public interest. And I just want to say that I know, particularly in primary care, there's been a particular challenge at staffing levels, ironically not because of moratoriums or other things. In 2019, there were 10,450 staff listed to primary care. And at December every year since, including the moratorium and pay number strategy, they've increased to now 12,500. And I absolutely appreciate embedded in that are the staff that were recruited to ECC, in which, of course, we know many staff, when we advertise specialist positions, they move to different parts. And as we develop health and social care systems, no different to any country in the world, we see that mobility of staff. But that's different to saying that there's any particular strategy to as it were, disregarding or running down any part of the service. My obligation is to take the totality of the service, which, by the way, is a workforce now that's increased by 25% in 5 years, and to demonstrate the effective use of that in the public interest first, not in anybody else's interest. So I really would challenge people to reflect on what the origin of what today's conversation is about and where it came from, as distinct from taking some sort of offence that it's not about something else. I'm quite happy to have conversations with people about any part of the health service. I do every day of the week, and in fact at the moment I'm engaged with the Department of Health and national colleagues to try and find resolutions and interventions specifically to the primary care and community waiting lists that we now also have. So they are the reality of the challenges, but the reality of those challenges doesn't prevent us from making specific progress. And I want to be very clear, I absolutely agree in a shared children's service response, and I absolutely agree in the integrity of that. But quite frankly, to date, in terms of achieving that, other than pockets of good practice, as a total system experience by the public, in very simple terms. And I see their message now that the strong mandate was for children's services. So if people could actually just let me get to that, then I think that I could get to that. The point is that there is a reality to the context, and challenging and finding solutions to ease the public burden primarily is not separating one service from another. In fact, you could go back to 2023 and look at the predominant focus, again, coming out of a crisis in respect of CAM services, and look at the majority of improvements across the country that have been achieved because of the particular focus in that. And so I would ask people again just to focus on where this is starting from, and hopefully see the benefit of a collective response to it. So to recap both on some of what you heard and some of what you didn't hear. And I think it's important to say, no more than people with mental health needs, or no more than children or adults with mental health needs, and no more than people with needs in the category of older persons, and no more than people with needs in any subset of enhanced community care, whether they're chronic disease or otherwise, all of which have seen expansive developments which have taken work out of what was traditionally the limitation of the primary care sector. We all know, and I think we all agree, and we all agreed in both Tullamore and Dublin, people don't live within one specific need or one specific issue or one care group. And so it's important that we allow space and time to develop all of our responses. However, in response to the immediacy of the challenges in respect of children's services, which we did talk about in Tullamore, and to go back to the point of entry of the single front door for children's access to community healthcare services. And that's where I do have a clear expectation that parents will no longer, or indeed other professionals will no longer face the possibility of filling out complex referral forms and processes for any service, having it submitted only to be told it's the wrong door, and having to restart the process again. And the reality is that is the true experience of the Irish public, whether we like it or not. We create those unnecessary bureaucracies, we create those unnecessary obstacles, and sometimes we do it in the name of alleged perfection, clinical or otherwise, when in fact we have to stop and pause and reflect on the complexity, not just of people's lives and of their needs, but the complexity of the services and structures that have evolved over the years. So the single front door is about that. It is about equally CAMS and primary care, not less than disability and not more than. And I hope that colleagues will see that in the short time frame that I've set for that, and in the presentation that you had earlier from Niamh and other colleagues, that can be achieved. It can be done. I'll be interested to see at the end of the day the strength of our real commitment to wanting to achieve that and do that when it comes to it. And yes, there are going to be resource pressures in areas that will challenge that. Those resource pressures should ultimately be seen in terms of challenging the waiting list and the waiting list numbers, rather than us not doing it. So whether we have enough staff to do it or not is different from the fact of actually doing it as the right thing to do and the right place to start. And so I'm very clear that change is the mandated change that I have made for the organisation, having listened to all of you and having listened to your colleagues and having listened to families. the length and breadth of the country, and having assessed all of the information available to me, I'm satisfied that's the right thing to do. I won't be agreeing or disagreeing with anybody as to whether or not it is or isn't. That is the decision, and that's the mandated decision, and that's the mandated position. And I expect that to develop in a very short pace of time, and I expect people to utilise it to the full benefit of the public, and hopefully to the benefit of the staff in all of categories of children's services, primary care, disability, and CAMS to that effect. So I hope people will work with that. If I can then just return to the admin support issue, which I think has been raised in disability, it has been raised in CAMS from different times, and it has been raised in primary care. I've been told if I invest more in administrative support, I will free up allied health professional time and clinical time to engage more with children and families. I've been told that. Well, let's see, because the increase in explosion in staffing to date and administrative staffing wouldn't suggest that in any part of the health service, not just in disability, primary care or CAM services. There are individual pockets where it might, and again, there are individual teams working with absolutely shoestring support, which is not appropriate and which we have to correct. And there are others that are more than well endowed and supported in that regard, who equally might find it difficult to reflect on the fact that we should have a standard. I certainly am committed to doing that. I'll have to do that through the estimates with the Department of both Health and Disability. And as I say, I'm against the tide because of the explosion beyond funded levels of all of our administrative grades in recent years. But I am anxious to try and support frontline practitioners to engage more with children and families, and therefore reduce their administrative burden. So I am certainly committed to trying to do that, but I will want to see the evidence before to be done on any wholesale basis, because unfortunately I have seen those interventions before, and I have seen them make very little difference to the amount of time that actually is available to the benefit of the children and their families. Also, if I can stay just with disability for a moment then, I'm also very concerned about our interpretation of, and I don't blame any frontline practitioners for this, but I am concerned about our interpretation of the rigidity of aspects of PDS, particularly as applies to how CDNTs do or do not work. I think there are many, many good things in PDS. I think there are many good things in the model. I've heard many good things from parents, and I've heard many good, very solid experiences from people. And I've also heard some dreadful, dreadful, dreadful stories, which ironically are in some cases to do with absence of being able to fill jobs, but in other cases are prevalent even where jobs are filled. So I will be looking for flexibility as to how those models are actually applied in response to the individual needs and experiences of people. There are a number of family forums around the country that I think people are aware of that are associated with children's disability services. Again, some of them very effective, some of them not. So the one thing I'm somewhat disappointed in is the experience where we haven't left, ironically, their family forums, but we haven't given families the full agency in how those forums would or wouldn't work for them. And so I'm anxious to give that back to them. I don't think that's a deliberate act on our part. I think it's just part of how public services try to organise things, and then it strays very often into that paternalistic space. I've met parents who've said to me the forums are absolutely useless to them. They don't give them any need or support. And I've met people who would say that they're the lifeblood of their support. So I will be giving a lot of agency back to families in that. But when it comes to staff retention as opposed to recruitment, yes, there has been a significant increase in the trajectory of recruitment. I think everybody knows we're challenged in different parts of the HSE, not just disability services, on retention. I have made some specific proposals on that to the relevant government departments about what that might look like, particularly in the context of health and social care professionals. I'm anxious to see how that does or doesn't progress. I think, as anybody on this call will know, if you make an intervention with a grade in one service, you automatically cause a significant consequential impact on another, as in the case of what some colleagues have pointed out of when you take the staffing context in disability or ECC as opposed to primary care. In relation to equipment, and this applies to primary care as well as disability services, I did make previous decisions in respect of the maximum time to approve the allocation of prescribed appliances for children to be 3 weeks. I've met lots of people who've told me it's anything but, and I've met some people who've told me that that was a great experience for them. I will be reissuing a full clarification and mandate to the regions and to the IHA managers in respect of that, and that will include equipment prescribed by primary care professionals and also disability services professionals. I'm not sure what the prevalence of it is in CAMS, but of course same rule of thumb will apply. And that's not the traditional aids and appliances that we might associate with physical and sensory disability, such as assisting devices, but also the more modern day specialised equipment that can help with speech development and other parts. So I'll be making that clear, and that will apply right across the range of services, and part of it will be about assisting that shared front door between primary care, CAMS and disability services. And I hope again that clarity will be there. I said the waiting list monitoring Aoife mentioned in respect of particularly assessment of need. Can I say that before anybody else asks, I would say to you that the reform of assessment of need is critical in my view, not just the legislative platform on which it's built, because I don't believe legislation has kept pace with the progression of practice and insight, but also in terms of how we apply it. I will be specifically paying attention to that, but again to assure colleagues, I'm particularly focused for both adults and children on the very difficult challenge that our waiting lists in primary care have and have become. Part of that associated with staffing in the shift to ECC, part of that associated with other deficits that have existed, and part of it, of course, just an increase in demographic demand. The one thing we are absent significantly, as everybody will know on this call, and nobody needs me to tell them, in primary care and disability services and CAM services, even though there have been discrete pieces in different parts of those, is the basic ICT infrastructure to manage and process manage the pathway of even things like referrals and so on. We will pay attention to that, but I'm not waiting for that to happen before we start to reform how we do our business. We can't. At the moment, if we're operating a paper-based system, there's no difference to operating that on a single front door as opposed to multiple front doors. I see somebody asked, is there any update on disability unit put together in the Department of the Taoiseach? And just to mention that in that context, there is now a very regular Cabinet Committee in respect of disability services. It recognises that disability is not the remit or the sole remit of the health service, but needs to see policy reform across government. And I can assure you I attend those Cabinet Committee meetings, and they are very active and there's very significant challenge to every government department, including social protection, transport, education, special education, Department of Further Higher Education, in terms of workforce supply and generating additional placements, which they are doing. And the challenge then comes back to us to increase the clinical placements consistent with the size of our workforce to be able to generate the workforce of the future. Interventions around time to register with Coro and other things. So there's quite an amount of work goes on at cabinet level, and that is facilitated by the Department of the Taoiseach and my colleague Liz Canavan, who's leading that, and I'm sure you will hear more about that as it emerges in the background. Part of that discussion is to try to take away some of the obstacles in the background and cut through them, rather than having frontline staff tied up repeatedly on them. People will be aware, people will have heard that there was a position where the issue of provision of therapy services in special schools and in special education, and it was on the agenda, it was off the agenda, and it was there long before any moratorium. And for those of us who are around long enough, I can assure you it's been there for a very long time. The government has made a decision that it is proceeding to build an education therapy service that will start with special education, but doubtless will over time progress. You can imagine the amount of work that needs to go on behind that, as to making sure that we don't simply build another part of government that hoovers up the same workforce without at least the possibility of ensuring that there is the appropriate connections and integration established across the different organisations and professions to give the best possible chance to the children and families at the receiving end of that. But that decision is made, and particularly for, I think, allied health professionals on the call, I would say you most likely will see the progression of that recruitment in the coming months. And of course, ultimately that is a matter that's a matter for individual professionals as to choice and career choice and so on. I do see one question: can we get primary care and CAMS to attend the cross-sectoral government meetings? Those are ministerial meetings. I do attend them, and obviously I do represent the totality of the health service, and that does include primary care and CAMS. I can assure people of that. So there is quite a bit of work to be done and being done. Perhaps the one thing that we've been most challenged on is there hasn't been an absence or shortage on plans, but there has yet been a challenge on implementation. And yes, some of that is to do with recruitment, absolutely accept that. Some of it is to do with resourcing, accept that. And some of it, unfortunately, is to do with our own lack of pace of urgency about some of these things. So the primary focuses for this year I've outlined to you. They are for this year, so they're not years off. There's obviously other policy decisions and developments to be made, which will progress beyond that. Yes, and I accept, of course, that the workforce is a limited pool. It has been the same in the health service. Every time a new initiative occurs in a hospital, staff get taken from somewhere else, and same in the community. It's a feature of an increasingly global moving workforce, along with a very significant development of methodologies and modalities, most of which are now based on the principle that every service should operate on an MDT basis. I'm not sure that I'm going to get to change that in my time, but that is part of the backdrop. Thanks, Aoife.
Thanks, Bernard. As we come to the conclusion, there's a number of questions there, so we're going to bring them into themes, some about the Autism Protocol, some about staff allocations. So we're going to collate them and we'll actually respond to those questions and share with those people who are in attendance. Also, can I ask each and every one of you, as we return to your teams, people have different focuses, CD&Ts, primary care, and the disability and CAMS and primary care. What we want to do is to improve services for children, front and foremost. It's not about they're on my team, our time. And we will have to do that through a variety of different initiatives, which we've presented here today. can you all please think of 3 positive initiatives and 3 positive changes that you've heard today and share them with your colleagues. Share that news and just present it and let that knowledge be shared among your teams that you're working with across all disciplines to improve children's services. I'd like to thank each and every one of you for your time here today, and we'll be back with more information on our webinars. So we have 4 upcoming webinars, one on respite, one on AON, one on the single point of access, and one on the Autism Protocol. And we will have face-to-face engagements being led out by the RIOs and the IHAs across the 6 regions, and they will be planned for October. So we've confirmed those dates in the coming weeks, and we'll share that information with you also. Thank you everybody for your time.